Thank you, everybody, for joining us for this webinar, sponsored and put on by Senzyme today. Greatly appreciate you attending and looking very forward to hearing about Dr. Scott's experience and talking about residual paralysis and the issue that it is. A couple housekeeping things before we get started. Please use the question and answer or the chat function at the bottom of the screen to input any questions that you may have. We may stop periodically and answer questions or wrap them up and do them at the end. But any questions you have, we're happy to address at the end of the presentation. Everybody's on mute, of course, just like any other webinar. People are used to this, so I'm probably going over the ground rules for no real apparent reason. But everybody is muted and video's off. So Dr. Scott will take over here in just a second after I introduce him. And again, thank you for joining and hope you enjoyed this. So our speaker today is Dr. Alex Scott. He is an intensive care consultant at James Cook University in the UK. He's also a faculty tutor for intensive care medicine at the hospital as well. Completed his fellowship at the Royal College of Anaesthetists. Has an extensive background in anesthesia as well as critical care experience and publications, and also is a bit of an amateur photographer. We'll use the word amateur lightly. His pictures are actually very good, and you can actually see them if you Google his name for several of the pictures during the pandemic, and an avid cyclist, which I think plays into the story today as well. So without further ado, I will turn over to Dr. Scott. And Dr. Scott, thank you so much for doing this and looking forward to hearing your story.
Well, thank you very much. It's extremely flattering to be invited to come and speak to everybody. Housekeeping for me, I've just got a couple of screens in front of me, so if I'm turning away, I'm not ignoring things, I'm just manipulating some of the slides here. And let's see if we can make some things happen and share the screen there. Okay, so this is a personal story of residual neuromuscular blockade in PACU. And just to give you some personal perspectives, but also to discuss some of the science behind it. I'm aware at least one absolute expert has registered, so feel free to correct me if I go wrong at all. But it's quite a memorable experience of mine, and I've used it, talked to in a variety of circumstances. It's not because I think I'm a better anaesthetist or intensivist than anybody else. But I think residual muscular blockade is possibly an underestimated issue, and it's certainly something I will have done, not deliberately, to patients, and my experience has changed my practice. Declaration of interest. Senzyme have paid me for my time today. However, I was giving this talk in a very similar manner, and I'm not here to sell any particular of anything. This is a personal experience. So, the patient experience I'll talk through. I wanted to talk a little more broadly on whether post-operative residual curarization, as we call it in the UK, or neuromuscular blockade, is a wider issue than just my story. And I just wanted to spend a little bit of time talking about ROCURONIUM, which I feel is an issue that just bears a little examination on its own. Okay, so there are various unkind cliches about anaesthetists in the UK. I note from Gleikenflecken that perhaps emergency physicians are all cyclists in the US, but in the UK, we anaesthetists are famous for being obsessed with cycling and coffee. The reason I've blurred out my background is there's a very nice coffee machine to my right and my race bike on my left. So the story comes from when I was working in a city with tram tracks. I will never specify publicly which city or the anaesthetist involved, because this is an issue with a what and not who, and I would never make this a personal attack on somebody with no right to reply. As I say, this story could apply to some of my patients and a lot of our patients, and I don't think there's any unit in the world that has not, whether they acknowledge it or not, had experience with residual blockade. So very long day in ITU, cycling home in rather a bad mood because I was full of coffee but no food and refluxing very, very badly. And I managed to drop my front wheel into some tram tracks. Somebody driving a white Audi A6 just brushed past me. Very, very gentle contact, but knocked my front wheel into the tram tracks. Of course, that meant I came off, and I came off by putting my foot down. And because I was working off the stress of the day, I was doing about 25 miles an hour, so 40 kilometers an hour in European units, which meant my foot stopped, and all 220 pounds, 100 kilos of me carried straight on at speed. And what I did was move my talonavicular joint out of line, crack several bones, disconnect quite a few ligaments, and my ankle was mostly held together with blood vessels and some but not all of the nerves. We had a fairly character building attempt to reduce that fracture dislocation using nitrous oxide and morphine, which was unfortunately unsuccessful and ranks up there as one of the more painful experiences I've had in my life. So I had to go and have a general anaesthetic for a reduction and, in fact, an internal fixation. Very experienced anaesthetist, somebody as qualified as I am now, more qualified than I was at the time, who did his absolute best for me. Unfortunately, by the time I came to theatre, I'd been starved effectively for about 26 hours through not eating during my working shift. I was suffering reflux all the way up to my chin. So he elected to perform a rapid sequence induction and intubate my trachea to prevent reflux being an issue. Obviously, I don't know anything that happened apart from when I woke up. And my recall starts quite crisply. I can remember the trolley rotating backwards and being reversed into a recovery space we call theatre recovery, PACU, in the UK. And I pretty quickly realised I was in a lot of trouble. I had an incredibly strong urge to breathe, and I think this was hypercarbia driven. So all I wanted to do was to take very, very deep breaths. I was trying to signal for help, but I could actually feel the very shaky, spidery, sort of fluttery movements, and my head was lolling around. When I tried to take a deep breath, I could generate a reasonable inspiratory flow, but the problem is my upper airways were collapsing, my pharynx. So if you've ever woken up conscious of being snoring, imagine that turned up to the point of complete obstruction. And that took it from an unpleasant experience to really something very lively indeed. I was still refluxing. I could still feel that burning sensation of vomit coming up my esophagus. I could smell and taste vomit in the back of my throat. And I really started to think that I was going to aspirate, be unable to control my own airway, and end up ventilated in my intensive care unit. So it was a lively memory. I got sorted out. I believe I got a second dose of reversal. I was busy at the time, having exactly attractive attention by, in fact, flopping myself forward and using a very mal-coordinated hand to bang the oxygen mask off my face. Things got a lot better, but they didn't actually improve all the way to normality for many hours. And now I'm a large guy. This was all around my colleagues in anaesthesia and ITU. I ended up being parceled around the hospital, unable to look after myself. So immediately post-operatively, I went for a CT, was unable to transfer myself across CT trolley onto the CT scanner itself. I couldn't hold my head off the pillow. And what really surprised me was the diplopia. I'll talk a bit more what's behind that later on, but essentially my eyes were rolling in an uncoordinated fashion, which really dramatically added to nausea and vomiting. So I was pretty unwell for a while there, and it lasted, having gone to theatre in the morning, all the way into the evening. As an experience, it's humiliating, aside from the distress. And seeing my colleagues and my what we call house officers in the UK, so interns, I believe, in the US language, coming to see me and check on me, and being unable to stop vomiting when they were popping around, it's not a good way to go. So that's my story. Very emotive. It is. Obviously, with a leg in plaster, with pins in, non-weight bearing, I was off work for a while. Gives me a lot of time to do some reading. So when we talk about residual cryonisation and you interview anaesthetists or anaesthesiologists, as you call them, they will say that less than 1% of their patients suffer residual blockade. Fair enough. I would probably have said the same thing before this experience. However, there is a meta-analysis available that shows that it's actually a problem in 41% of patients. Obviously, my story was very dramatic, but if you go into the more subtle factors that I experienced, you're still causing suffering to a patient. And 41% of cases is quite striking. As an aside, we have just done a region-wide audit in the northeast of England, where I work, or using quantitative neuromuscular analysis. We got a similar survey result that less than 1% of anaesthetists thought it was a problem. And we found 40% of patients suffered residual blockade. So this is not an isolated issue to one hospital. It's not an isolated issue to one group of anesthesiologists, nurse practitioners, anaesthetic assistants, as we call them in the UK. This is happening quite commonly. Is it a problem? Well, psychologically, definitely. I've been very lucky. I knew what was happening. I also have spent some time freediving and taking underwater photos. I'm actually quite used to hypercarbia and needing to breathe, so it was something I could notice and control. But imagine if you have no idea what's happening to you, and all you know is that you have an intense choking sensation and your upper airways are shutting off when you try to breathe. Imagine then that that has happened to a child or somebody with learning difficulties or similar, somebody with a background life where a sensation of choking may hark back to a life event that was very, very traumatic. We know that residual blockade can delay discharge. We know that it can lead to pulmonary problems. So it will increase atelectasis, it will reduce your ability to cough and clear secretions. I deal with a phenomenally unhealthy population with very, very high rates of obstructive pulmonary disease, obesity, asthma, similar things. So the inability to cough has the capacity for them to end up moving from my anesthesia practice all the way into my ITU. Aspiration, as I came close to suffering, we all know is a disaster. Mendelssohn's case series included some very, very sick people originally in the 1950s. Now, if you add a bit of respiratory disease on top, it's very easy. And I have certainly had patients aspirate and end up on the ITU with a tracheostomy. And there are cardiovascular implications. My coronaries, I would hope, are reasonably intact. But I did desaturate and I was cyanosed, and I know that because the recovery nurse announced it quite loudly. The cardiovascular implications, had I had a critical left main stem stenosis, I think are fairly obvious to the people who would tune into a seminar like this. I talked about this on Twitter several years ago, and it was interesting. At the time, there was a large debate going on about paralysis before hypnotic in emergency intubations, and some stories started to appear. I don't know who Bad Bearman was, and he wished to remain under his pseudonym, but he suffered the dental issues for 40 years of being awake and aware and a neuromuscular blockade. Mitochondrial leave may be well known to some people. As an ITU nurse who's had some awful experiences, but including being fully aware under paralysis. She's a mother. She would rather leave her family and die than experience what she went through again. These are the more extreme examples, but you can certainly, with very little imagination, picture the people who will delay seeking healthcare for significant issues, have phobias of general anesthesia because they don't understand what happened to them. It wasn't fully diagnosed. They haven't had an explanation. And most of all, they don't have a promise it won't happen again. Now, I hark back to my training, and I was certainly trained that by some people, not all, that if there's good diaphragmatic function, the patient can take good breaths with a good tidal volume while still anaesthetized, then paralysis has worn off and it's safe to wake the patient up. Fortunately, this isn't true. The different skeletal muscles of the body have a differing sensitivity to neuromuscular blockade. The vocal cords and the diaphragm, and I would argue for sound evolutionary reasons, are very, very resistant to neuromuscular fatigue and neuromuscular blockade. So they are some of the first to return function. That's my excuse to my surgical colleague when the patient coughs, just as they're operating. But if we work our way down, you can see that abdominal rectus, which is essential for coughing, and then pharyngeal and extraocular muscles are extremely sensitive. I would argue that a lot of my nausea and vomiting was due to the disconnect between what my occipital lobe was expecting and my eye movements were doing. Our occipital lobe at all times reprocess our visual experience so that we experience the world as a still place when our eyes move, and we experience perspective shift. Actually, if you expect your eyes to move and they do not, it is equivalent to a kind of seasickness. You can actually simulate it. If you press through your eyelid one eye, you'll feel like the world is rocking around you. The reverse is true. If your eyes do not move when your occipital lobe is compensating for it, you will feel the world is tilting around you. I don't have strong evidence of this, but my feeling, having had this experience, is that extraocular muscle paralysis is going to contribute to your post-operative nausea and vomiting rates. And that has huge knock-ons. It's the commonest reason to be admitted after day case surgery, and that's resource implications, certainly for something as resource restricted as the National Health Service in the UK. We cannot afford to be admitting these patients overnight for a preventable problem. When I say we cannot afford, we literally do not have the bed space to achieve it at the moment. Okay, emotive stuff. Is residual curization a problem? Well, the evidence is out there that yes, it definitely is. And you can see on this slide that we have all patients getting trainer 4 ratios that are usually reasonably predictable, but there are always, and I don't know if you can see my mouse pointer, these flyers. And we're talking about single intubating doses of 0.6 or 0.1 milligrams per kilo. You can see that we have flyers here all the way up to 5, 6 towards 7 hours after a single intubating dose. Atrocurium is commonly thought, along with cisatrocurium, as one of the more reliable drugs. But even here, we've got somebody with some residual paralysis, reversible, but by no means reversed, at 400 minutes after an intubating dose. That's certainly not something I would have looked for prior to my experience. But I also wanted to focus in on ROCURONIUM in particular. And within my own hospital, I teach about this a lot. And I have to be very careful what I say, because I don't know about residents in the US or elsewhere, but registrars and core trainees in the UK certainly have persuasive folk beliefs that go around because of the hierarchical structure. It comes to the point where people are telling stories that Dr. Scott will berate you and destroy you if you use ROCURONIUM. ROCURONIUM is an essential drug in modern anaesthetic practice and in modern ITU practice, and certainly I use it on a almost daily basis. But what I wanted to draw your attention to is the sheer number of these flyers with residual blockade all the way out in the very long periods, and this has implications for a lot of practice. Certainly the UK, we can diagnose brainstem death at 4 hours, and yet if somebody's had an intubating dose of ROCURONIUM, it is entirely conceivable that they may have residual blockade, which is a well-known brainstem death mimic. If you go all the way back with ROCURONIUM to when it was Organon 9426 in the developmental stage, you can see that the duration of action recovery indices are very, very constant. However, this is in healthy volunteers. When you look at elderly patients and compare them and references available on request, you can see that onset times are very, very constant. And cisatrocurium, you can be waiting an awfully long time. But what concerns me is the offset. You can see that there's large variation, and recovery index, time to go from a trainer 4 of 25% to 75%, or 0.25, 0.75, can vary very, very wildly, very greatly, and particularly with the elderly population. We've again got these flyers that are very far past what we would normally in clinical practice assume to be the case. So how do we prevent this? Well, neuromuscular monitoring really has to be the way forward. If you ask anaesthetists, anesthesiologists from clinical observation, there will be less than 20% agreement with the trainer 4. We bring in qualitative monitoring, so attach the nerve stimulator, look at the trainer 4 by observing the twitches of the thumb. We're only picking up fade clinically when the trainer 4 ratio is less than 0.4. Now, 0.5, 0.6 is a patient who's not reversible according to UK practice. reversing with glycopyrrolate and neostigmine. And we should not actually wake the patient up till a train of 4 of 0.9 or 90%, as your device shows. If we cannot discover fade till it's below 0.4, we cannot reliably analyze when a patient is reversible and when they're safe to wake. And the big paper, the bold paper, has the conclusion that the depth of block cannot be guessed, inferred, or assessed by subjective means, regardless of one's clinical experience. So we have moved to the point that now the UK guideline setting authority, being the Association of Anaesthetists of Great Britain and Ireland, quantitative neuromuscular monitoring should be used whenever neuromuscular blocking drugs are administered throughout all phases of anaesthesia, from before initiation of neuromuscular blockade until recovery of the train of 4 ratio to greater than 0.9 has been confirmed. I have spoken about this and my experience in several places and several hospitals now, and it's very interesting. I started my anaesthetic career when SATS monitoring, so saturation partial percentage of oxygen, was within 5 years of being a compulsory part of anaesthetic monitoring. I also speak and teach point of care ultrasound, and I see the resistance to this is identical as the resistance to end-tidal CO2 therapy, point of care ultrasound, use of ultrasound for vascular access, SATS monitoring, gas analysis within circle systems. Lots of people will acknowledge this as an issue. Lots of people will acknowledge that something has to be done, and they will all agree that somebody else has to do it, but it's not a problem in their practice. And I would challenge everybody that the available evidence, including my anaesthetics, suggest that my clinical ability is not enough to wake people up reliably without an element of residual blockade. To labour the point of ROCURONIUM, it's sold as Esmeron in the UK, which raises the question of why Sugammadex is called Bridion and not Esmerof. The US, I believe, look at GW here to check that Zemiron is the marketing name. The FDA have been given to warn in the pediatric population that there is a dose-related trend towards increasing duration of action of Zemiron. The practical significance of this trend is minimal because individual variability at each dose is greater than the trend amongst each age group. You cannot look at a patient who's given ROCURONIUM and predict their offset without measuring the offset. So I get tired of my own voice eventually. Residual blockade is real. It's distressing. I was lucky. I knew what was happening. I've not had PTSD. I've not felt the need to sue anyone. But it's still, my TripAdvisor rating as an experience is 0 stars. I do not recommend people go through this. And it is harmful. It has, beyond the psychological, serious physical harms that would affect both the service you give, the quality of the service, and the outcome for the patients. I think we need to be very cautious with these drugs, and we need to measure. It is not something that happens to other people. And believe me, I've traveled to anaesthetic departments in the UK, and there have been blazing rows. This is a problem, of course, for the registrars, or this is a problem for some other group, or there's a lot of hospitals with more than one site in the UK. This is a major problem on the other site, but we don't see it here. I'm afraid it is my firm belief that it is a problem for me, and it is a problem for everyone who uses these drugs. You cannot trust your eyes or your experience. Those are essential. But I have one more experience that makes me not rely in this specific regard on my own experience. ROCURONIUM, and I'll say this very clearly, is an incredibly valuable and irreplaceable drug. It is unpredictable in offset. Pick your indication. I'm very, very much welcome any questions anybody might have. Let's see if I can unshare my screen now. Stop share. Thanks very much.
Yeah, absolutely. And we do have a couple questions for you, so I'll fire them off if that's okay. One question that came through was, and I may have missed it, so I can't really answer it, but it may have been missed. But so you were reversed, I assume.
Yes.
In your experience, okay, and you were reversed with the neostigmine, I assume.
Glycopyrrolate and neostigmine. However, The common trap, I don't know how it's prepared in other countries. In the UK, almost every anaesthetic drug comes in the correct dose for a 100-kilo healthy adult human being, except for reversal, which is half. And I am not a small man, so I got a half dose for my body weight.
Okay. Awesome. And did you review your chart?
I tried to, but I got some things. But so another thing about UK practice is you are not allowed to look at your own notes. You have to go through the hospital and request them.
Yeah, it's the same thing in the US. So.
And it's very much frowned upon to be involved in your own care to the point of regulatory issues. So I got a quick glance. The problem was my eyes were rolling about all over the place, so it's quite hard to see.
Okay, cool. So here's some additional questions. So is quantitative monitoring protocolized or required at your facility? And then if so, what do you all document as a part of that protocolization?
So I have the ultimate respect for my colleagues, so I will not slag them off. This is like anything with a change in practice. There's always some kind of hysteresis and lag phase before it is fully adopted. My practice is that, well, firstly, it is a minimum standard under the Association of Anaesthetists of Great Britain and Ireland guidelines. What that means is it doesn't actually come with a criminal prosecution that, you know, there's a legal standard of its own, and you can nothing can be done to you until there's negligence demonstrated, but failure to use this would be the standard where it would be considered negligent if a patient then sued for inexperience. What I do is I document at the end of the anaesthetic the train of 4 from a quantitative neuromuscular monitor, and then I document that reversal has been given after that's been taken, if it's appropriate to give, and I document that it's given in the correct dose for the body weight. So that's typically at least 1.5 vials, 2, sometimes more in UK practice. And then I document after that an appropriate period that the train of 4 has exceeded 90% and it's safe to extubate the patient. There's a trap here though, which is glycopyrrolate and neostigmine have a shorter duration of action than a very prolonged block. So we do see recurization. So if somebody stays enough in PACU, as a lot of patients call it, they can be absolutely fine with your quantitative neuromuscular analysis. You pull the endotracheal tube, they are fine. They come back an hour and a half later and they have all of the issues you might experience with residual curization. And that is particularly an issue with ROCURONIUM, I find.
Excellent. This person said, thank you for sharing your experience. Why do you think ROCURONIUM has such variable offset? Genetics, age? I
think that's a very good question. I think there's, if somebody can find funding, there's some research to be done so that we can predict it. My understanding that ROCURONIUM is excreted unchanged in bile to a significant proportion. I suspect having not eaten and having a lot of morphine, which does tense the sphincter of the body and prevent biliary excretion, that maybe my biliary excretion was very low indeed at the time. Maybe I have a genetic subtle predisposition that I don't metabolize, you know, the remaining metabolism of ROCURONIUM maybe doesn't happen as well as me. I know that I'm extremely sensitive to codeine. So 10 milligrams of codeine will put me, you know, with GCS of 12 or so and in trouble. So I don't know if there's any link here at all. This is something that would have to, I think some charitable research fund could look at.
Interesting. This is actually a really cool question. Well, I won't say cool, but good question. How much of your experience do you think is revealed or apparent to someone who's reviewing your chart? So quality, you know, person who would go back and look. Do you think your experience is adequately reflected in the documentation and charting?
I haven't fully looked at my own documentation. All right, I was a junior doctor, so UK language, you're a junior doctor till you're a consultant. there's still a hierarchical structure, and I didn't want to cause a lot of offence at that time, so I didn't go through the whole thing of raising issues, and I certainly didn't sue because I haven't suffered serious events. In general, the documentation that should be performed is there should be a note on the anaesthetic chart for difficulties and complications. The management I had should have been recorded, you know, chin lift, jaw thrust, oxygenation, extra reversal, I think is what happened. And then we have something called DATIX in the UK, which is an incident reporting system. So there should have been a factual incident report because this is defined as a critical incident in our practice. So in theory, you should not attract significant trouble if you report it yourself. You should attract significant trouble if you hide your mistakes. I haven't gone in great detail into my own case, but that's what should have happened.
How long do you should quantitative neuromuscular monitoring be left on in the PACU? Could be a challenge in younger and older patients.
Yeah, absolutely. But the first thing to know is ulnar nerve stimulation does hurt. So I tend not to leave it on once the patient is awake and extubated. How much it hurts depends very much on the patient. But having had a very salty old anaesthetic nurse give me a non-quantitative neuromuscular analyzer to hold in my hands, and then he triggered it, which was his idea of a very funny joke. It's not completely comfortable. And there was an outbreak of harsh language after that. I think it has to be completely available in the PACU. In any environment where you're going to give neuromuscular blockade, I think it should be available. And that goes for trauma bays, what we call resus rooms. Because if you're intubating somebody who has a large intracranial bleed, it's very strongly indicate them to keep them deeply neuromuscular blocked. So why are we just pretending that we think we've done that? Let's check. It's not in the standards in the UK for that, but I think it should be. So basically, if you're using a curium or a ROCURONIUM, or you're looking after patients who've just recovered from them, it has to be available.
Okay. The impact of Sugamidex and quantitative monitoring is obviously a big question that a lot of people ask and tend to be a pushback. So the role of quantitative monitoring in patients who or in practices that reverse with Sugamidex. Your thoughts on that?
I'm not an expert on Sugamidex. I do use it, but we're very restricted here because of cost. One of the things I think is that when we're talking about quantitative neuromuscular analyzers and comparing them to a state-of-the-art anesthesia workstation, they're cheap. Bridion Sugamidex here, I don't know how much you pay in other countries, but it's expensive stuff. So if you're using a large number of vials and you are using deep blockade doses when the patient is lightly blocked, there's a chance for you to save quite a bit of cash here. You know, if your patient is very nearly reversed and you're using 16 milligrams per kilo, you are essentially shoving money away. Now in the NHS, that's somebody else's operation or another member of staff that we don't get to hire because of the money. In private resources, that's the margins that keep places open. I think the other thing is we really shouldn't be at this stage in 2022 treating medicine as a complicated subject. Medicine is complex. We need to perform experiments and check the outcomes and not just fire in drugs and assume that they've worked. If I use Sugamidex, I check it has worked. You know, it's going to be much rarer. If you give Sugamidex enough, you're going to get delivery failure. You're going to put it in through that intravenous cannula that's no longer working. You still wake up the patient paralyzed. Check it works.
Yeah, absolutely. Another one came in through the chat box is clinical director of an academic medical center's adults PACU. Would instruct that emergence from anesthesia not be permitted until sustained tetanus was demonstrated. Comments on that?
It's interesting that sustained tetanus is not part of the UK guidelines. What is part, and is largely historical now, but is part of our sort of training, is post-tetanic count. It's been a while since I've used it, but I believe a post-tetanic count is 12 strong twitches after a period of tetany. Don't quote me on the exact number. Whereas I've got no experience of using tetanus itself as a measure. And then you get into the things of what's sustained, what's tetanus. If you put quantitative neuromuscular analyzers on induction, you will find that there is no fade with ROCURONIUM atrocurium as you would expect on emergence, because fade is a product of the failure of mobilization of acetylcholine which is a function of prejunctional receptors. So fade doesn't initially appear. So if you've got a profound block early on and you've woken somebody up, you won't see fade. Now, can you at that point analyze tetany by its strength? So that's beyond my scope of practice. But if you've been a clinical director of an academic medical sector for 30 years, your experience exceeds mine. I think the most important thing is you do something about this. You recognize it as an issue and you do something. For me, tetany is an approach I'm not familiar with. But when I've got a box that gives me a number and I can relate that to the UK guidelines of when to reverse people, I think that's far more useful for my practice. But I would not say that in a way to disrespect quite an incredible degree of experience.
Awesome. One other question was, obviously your main practice is an ICU. So during the whole COVID surge and the number of people that you probably had paralyzed, did you guys find that you were using more quantitative monitoring in the ICU?
Yeah, so we've got rid of our non-quantitative analyzers. We don't have our own in ICU. We borrow from theatres, which was easy because theatres weren't doing so much and all of the anaesthetists were elbows deep in COVID. I use it to check that I have achieved paralysis. The other thing is, on occasion, you get that patient who is paralysed and proned, and we did have to use ROCURONIUM, and on one occasion it got desperate enough to use pancuronium. You paralyse, you prone them, they come down to 21% oxygen in 16 hours. It's rare, but it does happen. Where the management then is sedation hold. If their hypoxemia is resolved, you want to get them awake and moving, get that tube out. Check. Because a prolonged infusion of an aminosteroid or repeated boluses of something as unpredictable as pancuronium, you really do want to check. The other issue I use it for in ITU is brainstem death testing. Is extremely protocolized in the UK with no latitude whatsoever. It is either done perfectly or it is what actually happens is you are recorded as dead at the moment the first set of tests are completed. Residual blockade is very definitely a brainstem death mimic. It is on the checklist that comes from the Academy of Medical Royal Colleges in the UK. And I have seen residual blockade after repeated boluses of ROCURONIUM. We have an excellent pre-hospital medical team here who will intubate with doses of 1.2 milligrams per kilo of ROCURONIUM. If they have a catastrophic head injury, a standard practice for one of our registrars, our residents, would be to reparalyze with an extra dose before going to the CT scanner, demonstrate the catastrophic head injury, come back. Before transfer from the emergency department to ITU, they would reparalyze again. And I have seen at 24 hours a residual degree of blockade from ROCURONIUM. So I check everybody now, unless it has been days and days, 4 or 5 days. But if we're looking at end-of-life care decisions and brainstem death testing before organ donation, I very, very definitely check if they've had ROCURONIUM in the last 24 hours.
Awesome. Well, that was our last question. So again, thank you so much. Thank you all for attending, and we greatly appreciate it. And hopefully everybody learned a little something. And Dr. Scott, it was absolutely wonderful. Not wonderful for you to experience this, but wonderful to hear about your experience and how it could change clinical practice moving forward. So thank you so much, and we greatly appreciate it.
Thank you very much.
All right. Thanks, everybody. Have a great day.